little bit more, keep the mics. Not my disco. This is my presentation disco. Yes. Now my disco. So people want to know what is a smart ID here. The smart ID, I checked the Cambridge dictionary textbook, what is smart ID. The quality of being intelligent, able to think quickly, or intelligent in difficult situations. Most of the ICs are difficult situations. You need to think not only smart, you need to think intelligent and need to get the answers so that your patients can go back home. So you mentioned smart means specific, measurable, achievable. Yes, these things should be there. That's what ID is all about. Yeah. So a lot of things people are asking about just before the panel discussions. People are asking when to use combination therapy. So I asked my bot, what is a combination therapy? What came to the answers? Depends upon the severity. When for MRSA bacteria, when do you want to use a combination therapy? Severity of infections, clinical evidences of persistent bacteria, specific combinations. What combinations recommended? Sertraline plus or minus vancomycin or daptomycin, or sertraline plus or minus rifampicin, depends upon what you think about the source. So this is what my bot is telling. What is the thing? Next questions people are asking about what is the role of MRI or this is CT X-ray imaging for a suspected spondylolisthesis in ICU. I put specifically in Indian ICU. Next slide, please. So next slide, specific Indian ICU. The guidelines clearly shows Indian ICU. If you think spondylolisthesis, which has got most sensitive, what most specific, what is most specific. Come back. Okay, this will come there. Don't worry. So previous thing I asked, what is more specific? MRI has got more sensitive, more specific compared to X-ray. Suppose if you want an ideal modality of investigations for a suspected spondylolisthesis, you need to do MRI. X-ray lacks sensitivity and specificity. So this is what. So I told about what smart ID. Now come, whatever questions you want to shoot, I can poke a couple of questions with the bot, then my bot will take over and you can shoot the questions to the bot. So already all set? I think my voice is already. Okay. Okay.
Hello, hi.
Okay. So,
Hi there.
Hi.
I can assist you with your questions about managing infections and fever in patients.
Okay. Indian ICUs. Lot of Indian intensivists are sitting here. So, what common bacteria you encounter in Indian ICUs? Can you tell which bacteria is common in Indian ICUs?
In Indian ICUs,
Yes.
common bacteria include Klebsiella pneumoniae and Escherichia coli, E. coli, Acinetobacter baumannii, Pseudomonas aeruginosa, Staphylococcus aureus, including MRSA. Would you like more information on any specific bacteria or its management?
Yes.
In Indian ICUs,
Yes, we know. Yes, we know Indian isolates are carbapenem resistance. Indian isolates are carbapenem resistant one. So, what should be the empirical therapy you would consider for a patient with severe sepsis due to carbapenem resistance, infections in community acquired pneumonia?
for severe sepsis due to carbapenem-resistant infections, empirical therapy often involves 1. Polymyxins, e.g. colistin or polymyxin B, cyclane, ceftazidime-avibactam or meropenem-avibactam, if available and susceptibility confirmed. 4. Aminoglycosides E, amikacin, as part of combination therapy. Given the complexity, it's crucial to consult an infectious disease specialist.
No, you are the ID specialist. So you can't answer the ID specialist here. You are the ID specialist. And you know, India, meropenem, vaporibactam is not available. And ceftazidime-avibactam, because Indian ICUs are loaded with the NDM1. So you still want to use ceftazidime-avibactam as a monotherapy?
Given the NDM1 prevalence in India and the unavailability of meropenem-avibactam, here's a more suitable empirical therapy approach. Polymyxins, e.g. colistin 2. Types 3, aminoglycosides, E, amikacin in combination 4. Phosphomycin as combination therapy, if appropriate. Please remember, definitive therapy should always be guided by culture and sensitivity results. Thank you for the reminder on NDM1 prevalence.
I agree with you, but unfortunately for a pneumonia, what is the penetrations of aminoglycosides into the lung? Do you consider as a second line or as a last line of options? What do you think about aminoglycosides? The PKPD of aminoglycosides is okay?
Aminoglycosides, like amikacin, have poor penetration into lung tissue, making them less effective for treating pneumonia. They're typically used as adjunctive therapy rather than primary treatment. Due to their pharmacokinetics, PK, and pharmacodynamics, PD, they are often reserved as a last-line option for part of combination therapy rather than monotherapy for pneumonia.
So don't think I have tuned the thing and is answering thing. You just put your questions to my bot. Anybody want to ask any questions to my bot? Nobody.
Sure. I'm here to help with any questions you or anyone have regarding managing infections and fever in ICU or non-ICU settings.
Okay, one question for you from the audience here. He's asking what is the clinical proof for milioidosis in general and in particular in ICU. Can you come back?
Certainly. Clinical clues for mucormycosis.
Not milioid. Sorry, milioidosis. Burkholderia pseudomallei.
Mucormycosis in the
Not
ICU
mucor.
can present with several.
You are not trained in milioidosis, sorry. Okay? We need to train you in milioid. Okay. Any other questions regarding bacterial infections? Milioid is not trained. I can tell you when a patient is an diabetic, when a patient is an alcoholic, when a patient has got CKD, this is a host. Usually in ID is three things. What sort of host you are dealing with it and what syndrome you are dealing with it. The host is a diabetic and the patient has a CKD, the patient
Managing infections is crucial to consider. One, understand.
Can you hold on for a minute? Okay. So the patient is a diabetic and the patient is a CKD and the patient is an alcoholic and the patient has got presentations of fever or any disseminated presentations in the form of pneumonia presentations or occult abscesses with elevated WBC count, and particularly you don't think this molecular panel is available everywhere. Suppose the blood culture bottle is going only aerobic bottle. It's not going in anaerobic bottle because Burkholderia, Pseudomonas, these all go in anaerobic bottle. Suppose you sell 4 bottles, only 2 out of 4 elevated WBC, elevated creatinine, non-diabetic, alcoholic. Definitely I can put my money on milioidosis or have a differential diagnosis. This is a subtle clue. I'll train my bot. Thanks for putting your questions. Anything in the Hasinito, Klebsiella, your ICUs, Canada, we are trained because this is a bot in progress there. So that's why take very few. Actually, in fact, yesterday, a couple of days only we are working on this bot. So it will take, even my voice will come, my avatar will also come in the future and answer the thing, not necessarily the same plan. Right now we train in English, but even in Tamil or any language you want, we can train them. Show any questions in bacterial infections. Anything in the bacteria? You want antibiotic choices? Or previous panel, I can pick it up and ask somebody has the panel there. Okay, the previous panel they are asking about isolation practices for Candida. So, which Candida species you want to do isolations, or you want hold on for isolations?
For a patient with an endotracheal tube E culture growing Candida, typically we wouldn't rush to start antifungal treatment unless there's clear evidence of systemic infection.
No, I'm asking about contact isolation precautions. Contact isolation precautions for Candida in the ET secretions.
Typically, routine contact isolation for Candida in ED is not necessary unless there's an outbreak or other specific infection control concerns. Standard precautions.
Which species of Candida would recommend isolation practices? Which species of Candida require contact isolation?
Candida species generally do not require contact isolation precautions. However, if there's a concern about Candida auris, which is known for being multi-drug resistant and can spread in healthcare settings, contact isolation might be recommended. Always check with your infection control team for the latest guidelines.
Okay. So, what should be your empirical therapy in Indian ICU for a suspected urosepsis?
For empiric therapy of suspected urosepsis in an ICU in India, a common approach might include broad-spectrum antibiotics such as piperacillin tazobactam or carbapenem, like meropenem, if there's a high risk of multi-drug resistant organisms. Always tailor the choice based on local antibiograms and consult with an infectious disease specialist.
No, actually I told you Indian ICUs are loaded with LDM1 and carbapenem resistance organisms. Still you want to go with piperacillin acinetobacter or you want to go up?
Given the high prevalence of NDM1 and other resistant organisms in Indian ICUs, empiric therapy for suspected urosepsis might include antibiotics like colistin or tigecycline, often in combination with a carbapenem, such as meropenem. Again, it's crucial to use local antibiograms and consult with an infectious disease specialist for guidance.
You can't consult. You can't consult. You are an ID specialist. You are the avatar of ID, so you can't consult an ID. So you need to tell the diagnosis and you need to tell the suggestions to
High
us.
resistance rates, I would avoid piperacillin tazobactam and opt for more potent antibiotics.
Okay.
Considering the context, given the high rates of resistance, I would recommend empiric therapy with a combination of colistin and carbapenem, meropenem for suspected urosepsis in India. This helps cover extensively drug-resistant organisms like NDM1 producers. Adjust therapy based on culture results and sensitivity patterns.
What should be the target level for vancomycins when you are using for MRSA bacteria? Previous panel was discussing about they want to measure the MIC levels and they want to measure the therapeutic drug levels. So what is an ideal method when you're using vancomycin to measure whether vancomycin levels are good or not?
For vancomycin, the appropriate target trough level for treating MRSA bacteria is generally 15 to 20 micrograms per ml. To evaluate therapeutic efficacy, both monitoring the minimum inhibitory concentration of the MRSA strain and regular trough level measurements are needed. Trough levels should be checked just before the next dose at steady state, typically after the fourth dose.
Any questions, please go ahead and shoot because it's not that raining, because the bot isn't raining, but you can shoot so that my bot can learn answers.
Thank you.
No, you can ask. You can't escape. You can wait and ask for the audience to make an ask. Yes, sir. Only you want human response. What to not respond? They want to have human responses. They're actually hesitant to speak to you there. Any questions from the audience?
Any data on Glabrata and Cruci in ICU?
Any data of Candida glabrata and Candida cruzi in Indian ICUs, you are able to get it? I will come back. So they want to discuss with you any data of Candida glabrata and Candida cruzi in ICUs. Are you speaking more? So when you do not know the answer, this is silence is the best answer. So I just reconnect you there. Yeah.
This call is being recorded for quality control and training purposes.
Okay.
Hello, I am.
Okay, fine. So what is the prevalence of Candida glabrata and cruzi in ICUs? Which one is the leader?
Candida albicans is typically the most prevalent species causing infections in ICUs, followed by Candida glabrata. The incidence varies depending on the setting and patient population, but Candida albicans is generally the leading cause of invasive candidiasis. For more detailed information tailored to specific ICU settings, it's best to consult with an infectious disease specialist.
No. You are a ID specialist. Sorry, you can't. I need to train you. Right. You are a ID, so you need to tell. So don't consult. You need to tell the answer to me.
Got it. In ICUs, Candida albicans is usually the most prevalent species of Candida causing infections. It's followed by Candida glabrata as the next most common.
I agree with the bot. Glabrata is more common compared to glabrata and cruzi. Glabrata is more common.
Understood. In most ICUs, Candida albicans is the leading cause of fungal infections, followed by Candida glabrata.
Any other
Prevalence
questions?
can fluctuate based on the patient population.
Any other questions from the audience?
Empirical treatment for infective endocarditis in case of prosthetic valves.
Candida glabrata, while still significant,
Not signed in ID, but they just check. Because it's 2 days only. I thought of intensive care, so whatever intensive care related infections only. Okay, one question for you. What is an empirical antibiotic choice for prosthetic valve infective endocarditis?
For empirical treatment of prosthetic valve infective endocarditis, the common choice is a combination of vancomycin and gentamicin, often with morphine. This covers a broad range of pathogens, including MRSA. Always follow up with culture results to tailor therapy.
Any other questions? So it's answering that. Yes, sir.
Post-COVID patient,
Got it. Any other questions?
post-COVID patient with mucormycosis, confirmed mucormycosis, post-immunotherapy, being amputated found to be resistant, even after 1 week of treatment. What is the next terms of life?
I try first with my bot, because bot is keen on mucormycosis, then come to my intelligence. So the question to you is, the patient has got post-COVID mucormycosis. They tried Hyatt B. Unfortunately, Hyatt B was resistant. What is the option for the patients with post-COVID mucormycosis?
Sorry for that, we disconnected the speaker. We are disconnecting it right again.
So for a post-COVID mucormycosis, patient started with Hyatt B. Unfortunately, Hyatt B was resistant. What is the best choice?
The best alternative would likely depend on the specific fungal pathogen and its susceptibility profile.
This is mucormycosis. You want a species of mucor.
In such specific cases, knowing the exact species of the candida can guide the
Not
treatment,
candida, mucormycosis, sorry.
such as caspofungin, mycofungin, or
Mucormycosis. Mucormycosis. You listen the questions properly there, because there's a connection. Disconnections happen. Patients with post-COVID mucormycosis, Hyatt B was resistance. Which one you would like to start?
In cases of post-COVID mucormycosis resistant to amphotericin B, options like posaconazole or isobuconazole could be considered.
So my
Both
board
are effective.
Okay, so post-COVID mucormycosis, usually Hyatt B resistance is very rare. If it is possible, we can start with isobuconazole, if not posaconazole. The priority is isobuconazole nowadays compared to posaconazole. Even the latest microbiology guidance, the European Society of Mycology guidance is ISABA, or you can use posaconazole, plus or minus still you can use hydroxychloroquine B if needed. So I'll go to the presentation start. So I think what is great is in evolution now. Maybe next couple of months, even more, whatever things milioid or when mucormycosis or Indian XU settings you can ask. So I'll come back how to use this bot in the future. So go ahead and I can use my presentation sir. So this is one of the help end for you. Apart from the bot is going to help you in any point of time. So don't think ID support is needed in persons. ID can provide you support 24/7. Even by call to this bot, the bot can try to answer. But bot is augmented. So don't think the bot will go because this is a HIPAA complaint one. Most of the time it won't give a specific advice. So who is responsible for the advice given by the thing? So whatever responses, it is checked by the ID also there. So it's not automatically going in there. Right now I just do the demo, but whatever call you are doing, the HIPAA complaint thing, so we need to check and we need to augment it. Some of the situations advices may wrong, but in the presence of ID, it will take it care. Don't worry about the bot is going to give you a wrong advice because it's augmented one. It's not artificial one. This is an augmented between human and artificial intelligence there. We are given just a couple of guidelines want to go through it. Hardly half an hour we given a time. Within the night it's ready there. We worked it overnight and it's getting ready right now. Okay, so this is the other information portal, we'll put it there. Right now, anything, for example, the melioidosis case you're speaking about, this is the latest CMA article. So this is one of the latest CMA article is coming up now. So this is the durations of the treatment for melioidosis. So if you want to get an updated knowledge about whatever thing in ID, there is a one-point source in infectious diseases is called a WhatsApp group. I showed in the last slide. You can join the WhatsApp group. If you want to get updated anything about ID, ICU or medicine, this is the source. We put a lot of already sources. This is for ICU people. What are the ventilator modes? What is the advantages and disadvantages? Don't take a Photoshop. So you can take join the group and you can see the thing there. What is the risk of Clostridium difficile antibiotics? What is green? What is yellow? What is orange? You can able to see. Almost all the information will come to you in your WhatsApp. So people say AI is dangerous. We put in AI. Anna Teresa is fighting with poverty. So this is the image come from AI. So this is AI. So don't think AI is not good. People used to say Google is not good. I agree with Google is not good. But AI depends upon who is handling the AI. That's most important thing. Don't think everybody can get the answers what I get from you. Just know the bacteria data as well as imaging modality for spondylolisthesis. It's not the answers. This is amateur. This is professional. So don't think about who is asking the AI, which modality of AI you are using, whether it's a ChatGPT 3.54 or 4 or 4 or it's a Gemini or Llama. What depends upon the thing and who is the person. That's most important thing. And what level of training you have. That's most important thing. So for example, those who don't have a ChatGPT or those who don't have artificial intelligence, you need to have this manual help. This manual help will work for you then. This is ideal, this is ideal. You need to have ID in your local setup. The ID should provide you the guidance and ID should help you there. So this is an ID for you. So, but unfortunately, nobody has got the luxury of ID all in our hospitals. So what we need to do, so this is an alternative to you there. This is an alternative for you. That's what a smart ID is. So I don't have a luxury. So I don't have a luxury means this is a luxury I got it. So I can use my bot to answer the thing. So the bot is going to answer you. The bot is going to provide you the shortcuts. So don't expect a long one. The short one is better. So this is a WhatsApp group I'm talking about. Those who want to scan this QR code, join the group. You can get the updates. You can post your difficult questions. You can get an expert. Not second opinion. This is an expert opinion for you. No need for consult the doctor over phone. But depending upon the legal realities, we need to come up with it. So this is a group, and this is a number you can WhatsApp also to get the answers. I'm happy to take a couple of questions. So smart ID is coming up. There's no need for standard ID should present. Smart ID can present, and avatar can come and answer. I want to do my avatar to talk. I want to talk down at the 12:30, but unfortunately, because of the logistic reasons and the cost reasons, I'm speaking in front of you. I want my avatar only speak to you at 12:30, but unfortunately, avatar is too costly. But anyhow, my avatar has answered your questions. In future, my avatar will speak and avatar will answer the questions in your ICU also in persons. That's the way forward. Thank you. Thanks for the opportunity. Any questions I'm happy with. Now manual is there.